Good morning, everyone, and welcome to the Vol Performance online workshop series. Thanks for joining us this morning if you're here in Australia, or this afternoon in America. We're really fortunate to have a great group of panelists this afternoon and this morning, and really want to thank Vol Performance once again for being able to afford us the fortunate possibility to speak to such fantastic practitioners. The goal of the Vol Performance online workshop series has been to facilitate creative discussions and enable practitioners to share ideas, best practices and their experiences. And today is no different. What we've been able to do over the last few weeks and months is lean on some of the world's best experts on certain topics for on-demand presentations. And this week with the Female Athlete Series, we've had some great presentations from Kate Beerworth and Tyler Collings, as well as another presentation that will be coming on demand from Claire Minahan from Griffith University around the female athlete and how we can better train and understand the female athlete. Today, we're fortunate enough to have our panelists live to ask them some questions around injury reduction or mitigation strategies, but also what we can better be doing to physically prepare female athletes. For those of you who haven't seen any of the on-demand content, you can access it via the link here, and we have some previous content on leadership series and some other upcoming series on the mixed martial arts athlete and some US collegiate athlete management strategies as well. But today, really fortunate, as I mentioned, to have 5 fantastic practitioners. I'm going to allow them to introduce themselves to you with the overarching topic of profiling injury risk, but also assessing performance within female field-based athletes. I'll get Tyler to introduce himself first. Tyler, if you can unmute yourself and introduce yourself to the group, that would be great.
Oh, thanks, that's Selwyn. So my name's Tyler Collings, and I'm a second-year PhD student at Griffith University, Gold Coast in Australia. And so along with Matt, who's one of my supervisors, we're looking at injury prevention in female athletes. So some of the studies we're doing is looking at field-based testing in female athletes, as well as looking at developing injury prevention strategies that are specific towards female athletes.
Excellent. I might throw to you now, Matt, as part of Tyler's supervision team, but then also some of the work you've been doing away from that.
Yeah, sure. Thanks, Selwyn. My name's Matt Bourne. I'm a lecturer and researcher at Griffith University on the Gold Coast. I'm a sports scientist or exercise scientist by trade. And I guess most of my background has been in the lower limb injury space, particularly hamstring strain injuries and hip and groin pain more recently. We've been really lucky to collaborate with Kate Beerworth and some of the other really great practitioners around the country to start working with some of our elite female sports to try to better understand risk factors for some of the more common and the more catastrophic lower limb injuries, and that's in an effort to optimize injury prevention strategies moving forward.
Yeah, fantastic. Some great research happening in this space, definitely. Kate Beerworth, I'll get you to introduce yourself, please.
Thanks, Selwyn. 2 Kates is always interesting, so we'll have to Kate B and Kate Mahony. So I'm currently the Australian Women's Cricket Physio and have been in that role for a year and actually took over from Kate Mahony. So, really lucky to walk into a space where female athletes are well supported at Cricket Australia, which is great. And prior to that, I worked with the Australian women's football team for 10 years. And after travelling with them, moved into just a consulting role really with FFA in regards to injury prevention and trying to translate some work that it's easier to do in the elite space down through grassroots to kind of really make sure that pathways for the female athletes are properly supported.
Yeah, the presentation, for those of you who haven't seen Kate's presentation on the on-demand, is fantastic, looking at some of the insights into the Cricket Australia component, but just also the female athlete globally. So really encourage you to view that. And Kate Mahony, Kate's given you a good intro already, but if you want to just introduce yourself.
Yeah, so I'm also a sports physio from Australia, and I worked, as Kate said, with the Australian women's cricket team for a number of years. I've also worked quite extensively in tennis, so as head physio for the for the women's draw for the Australian Open for a number of years, and with the Women's Tennis Association. And I was really fortunate in 2018 to be awarded a Churchill Fellowship. So I travelled worldwide to look at how SSM structures are set up around our female athletes around the world to try and bring some of these findings back to Australia. So I've had an interest in female athlete health and in injury risk, I guess, for a long period of time.
Yeah, fantastic. Looking forward to insights from different sports and how we can kind of learn from other sports to both help field-based athletes, but also what the crossover is. And our last panelist, Tim Hewett, probably doesn't need too much of an introduction, has done some fantastic research, not only in the female athlete, but in a number of other areas as well. Tim, if you can just introduce yourself to the group.
Yeah, thanks, Selwyn. So I'm Tim Hewett. I'm sort of the senior man of the member of the panel, as someone would say, the old fart. I've been in this space for more than 25 years, if you can believe that. And we did some of the early work. I'm a biophysicist and physiologist by training. We did some of the early work looking at female athletes. We actually did a study in our group in Cincinnati where we showed that female athletes we actually started out on looking at a study comparing turf, grass versus astroturf at that time, looking for differences in injury rates. And what we found was a 6.2 times greater risk of females than males. And that led us into over 25 years of research trying to figure out why females are more prone to injury per exposure, and gone down that road for a long time. So I'm happy to be here and interested to listen to the rest of the panel.
Thanks, Tim. You raise a great point there in regards to, I guess, the uniqueness of the female athlete. And when we talk about the female athlete and the uniqueness around physiologically, biomechanical considerations, and I guess what we think is important to train an athlete, I'd like to hear your thoughts around the unique differences between the female athlete and the male athlete from your research, as what is important when we're considering training female athletes.
Well, again, I'll go from our perspective from the anterior cruciate ligament. So if you look at boys and girls prior to adolescence are at the same risk level per exposure of an ACL injury. It's relatively low. Then what happens is boys and girls hit adolescence. As we all know, that's a scary time for both boys and girls for multiple reasons. And I like to use a car analogy. So when you hit adolescence, and girls hit adolescence at about, in America, about age 11 and 10 and a half to 11, boys at about age 12, 12 and a half. So girls hit that earlier, but they both hit a growth spurt. And to use a car analogy, both athletes get bigger. They get a bigger chassis. So say they go from a VW to a Cadillac. So they've got more mass, they've got longer levers, they've got a bigger chassis. But what happens very soon after the adolescent growth spurt in males, you get a testosterone boost that increases the power and the torque output of the motor or the engine. So, for example, a great measure of whole body power, like a vertical jump, actually, even in boys, as they get more massive, their vertical jump goes up. Whereas in girls, as they get more massive, they stay about the same. So boys, not only they get a Cadillac-sized chassis, but they get not only a Cadillac-sized engine, but a Porsche-sized engine, or a power of a Porsche engine. Whereas girls stay somewhere between, say, VW and a Chevy. They don't get that power boost. Now, the good thing is we can induce that, and that's been demonstrated. But what that leads to in these young girls without proper training is you can end up with a machine motor mismatch, meaning you've got a bigger machine with less power to control it. And some of the symptoms that you see are things like trunk dominance, a lot more because it's like putting an athlete up on stilts. They've got longer levers, their center of mass is higher off the ground, more difficult to control. So you've got more movement of the center of mass relative to the foot placement where the force is coming from, with your trunk and hip and knee in between. And so what that leads to is ground reaction forces that go lateral, especially in the frontal plane, to the joint centers, the hip and the knee, and tend to collapse them in. And so that leads into this whole development at that stage of neuromotor imbalances that we need to use neuromuscular training to ameliorate. We also can use those neuromuscular imbalances as cues and as screening tools to figure out where the risk lies and who's at greater risk, but also to use to target the neuromuscular training interventions.
Yeah, definitely interesting considerations, Kate. And Kate, with what Tim spoke about there in regards to the adolescent female and their transition, have you seen that within the sport cohorts that you guys have worked with, and how you've best identified that and then tried to train those capacities to limit the difference between, as Tim put it, the machine and the motor?
Yeah, definitely. I think certainly in terms of the age factor, here in Australia, we have, a population of 25 million and there is multiple of sports that are competing for that talent during adolescence. And often they make national teams at a really young age. So, we had our 2011 World Cup squad, we had 4 16-year-olds in a national team, which is quite extraordinary. And if you think about their athletic development before that, they only come into our system a year before, and prior to that have very little physical and athletic sort of development and support to try and mitigate some of those risk factors. So whilst we put them in then a high risk scenario from an exposure point of view, it's then being able to work back and go, okay, well, once they get to the elite level, what can we do prior to that? So being able to, have some tools that, largely can get some of those resources into that underpinning developing stage. And it's very much the case for Australian rules football at the moment here in Australia, where we have an elite competition and there's less support sort of in the feeder competitions, and that's relatively new in the scheme of things. So I think when resources are low and particularly, now when we're going forward in these COVID times where we might see funding in sport reduced in the short term, is looking at sort of wider scale strategies. And largely that's the neuromuscular training programs that Tim was talking about.
Yeah. And just to add to that, I think that brings up a really interesting point, Kate. Obviously, we've both had the same exposure in cricket. I'm working with Australian cricket, where you have these young athletes come in and, like Tim was saying, they're really physically not ready for the loads and the load that's going to be placed on them. But we need to continue to educate, not just get those programs to the athletes, but actually educate further up the chain so administrators understand why we need systems in place through the pathway program and why it's important to put some funding towards that. Because chances are one of their stars is going to come from that group, and they're going to come through really quickly. And if they haven't been exposed to any kind of formal training, or their training history hasn't incorporated any injury prevention programs in the past, it makes it really hard when they do get to that elite level to kind of protect them, I guess, or they come into that environment at a huge risk compared to their more athletically developed counterparts.
Yeah, you both raise great points there, especially in regards to Kate Beerworth, your question, your component around the ACL and the AFLW athlete. That's been well documented, the higher number of incidences that's been occurring since AFLW has come to a competitive competition. Tyler and Matt, you have worked with assessing these types of athletes and also some other female sport athletes. Is there anything that you've seen from a injury assessment perspective or a screening perspective that you think is important to implement for these athletes?
Yeah, so just for those that aren't familiar, some of the testing that we've done recently, we've been using the valve performance equipment, so measuring hip adduction and abduction strength, as well as Nordboard scores, and we've been assessing ground reaction forces using the force decks, as well as the Marculus human track motion capture system. And so, yeah, just to sort of touch on those age differences you see, we've collected data right from those 16, 17-year-olds who are starting to enter those sort of elite pathways right through to the senior AFLW players. And it is quite common for a lot of them to have very little training history, and perhaps not quite prepared for the demands of an elite game like AFLW, which is very physically demanding. And so a lot of these test scores that we see don't really change a hell of a lot from the 17-year-olds right through to the mid-20 sort of aged players. So perhaps there's not that development in things like hip strength that there needs to be. So yeah, I think implementing testing and identifying these players who maybe don't have the training history and then intervening to try to get them up to speed as quickly as possible is really probably the key with some of these female players.
You spoke about in your presentation and with some of the research around hip external rotation isometric strength possibly having a moderate association with injury in the female athlete. Is that something that you believe should be globally addressed when we're talking about injury prevention programs or mitigation programs for field-based female athletes?
Yeah, so I mean, we've just recently performed a systematic review looking at risk factors for female athletes. And there's some studies there's the evidence isn't super compelling, but there's some individual studies that show the association between hip abductor strength and hip external rotation strength and lower limb injury, particularly knee injury. So I think given the role that the hip has in controlling the lower limb, as well as the role it has during single leg movements, which we know are really important, and usually the movements that lead to injuries such as ACL injury, it's likely the hip is a real key area to target in female athletes for injury prevention. And so, yeah, I think the more we can implement hip training into the neuromuscular programs, increasing strength along with increasing the ability to control the hip is probably really key for a lot of those injuries that impact female players.
Tim, with your, I guess, extensive knowledge around that component of ACL injury risk and prevention programs, have you seen something similar with the importance of when we use the neuromuscular control programs, having a component of isolated hip strength plus global neuromuscular control? In male field sport athletes, we've seen the use of FIFA 11 plus and a few other, I guess, global programs. Do you think that those have the same benefit for the female athlete, or do they need to be tailored slightly differently for the female athlete?
First, from a prediction standpoint, so I completely agree with everything Tyler said. So what we've done over the last 25 years is we've followed large cohorts of both female and male athletes. For example, here where I'm currently in Northern Kentucky, we studied an entire county school system of kids grade 6 through 12. So that's in the US middle school through high school. And we followed those kids longitudinally, testing them biomechanically. And one of the parameters we test is hip ABA deduction strength. but we also test during a drop vertical jump the relative hip torques in all three planes: flexion, extension, ABA deduction, internal, external rotation. So when we followed those kids out originally in our 2005 paper that we published in American Journal of Sports Medicine, basically one of the 4 predictive factors we demonstrated, the biggest predictive factor was the symptom factor, the knee abduction, that abduction of the distal tibia, so inward collapse of the knee, or valgus at the knee, valgus at the hip, or adduction at the hip. So that was the biggest predictor, but also we demonstrated that asymmetries in relative hip abductor activation were also predictors in that model for primary risk. Now, for secondary risk, what we did is we kept following that in a larger group of athletes over time to see who went on to a second ACL injury. And here, the biggest predictor was the athlete who had a net hip internal rotation impulse torque at the hip. So when you looked at the profile of those kids that didn't go on to a second ACL injury, they had a net hip external rotation impulse. So they were using the hip external rotators to control and externally rotate, abduct their hip and femur so that they didn't get that hip adduction and collapse at the knee. Whereas those kids that went on to a second ACL injury had a net negative hip internal rotation moment, meaning at the hip they were allowing the ground reaction force to internally rotate their hip, adduct their femur, and valgus collapse their knee. Just that net hip internal rotation impulse predicted risk of a second ACL injury with almost 90% sensitivity and specificity, 8.5 times greater risk if you had a net hip internal rotation impulse during the drop vertical jump at landing. So absolutely agree, and the biomechanics of prospective cohort studies support that.
For practitioners who would be trying to assess that within, I guess, their realm where they maybe don't have any technology, how would you best give them advice on trying to assess that within their cohorts?
Simplest way to do it is either a vertical jump or a drop vertical jump. I recommend the drop vertical, but if you don't have a 30 centimeter or 1 foot high box, or you want to just do a vertical, that's okay. But you're going to look at the landing, and basically what you're going to do is pull out your cell phone. You're going to take a video of them as they drop off the box or as they jump up to their. The key is you have to get a maximum vertical out of them, because that's going to help you for multiple reasons. For one thing, the really nice thing about the drop vertical jump test is it has 2 components. It has that power component of the jump, but it also has a neuromotor component, because if you drop off a box and you actually can jump higher, you actually have good coordination. So you're measuring neuromotor coordination along with pure power. Whereas if you don't have good neuromotor coordination, like in a lot of these young adolescent kids during that peak height growth spurt, you actually jump lower than you do off the ground. So you can use that as kind of a tool if you're measuring their max vertical jump height. And you can look at the kinematics, just pull out your cell phone, take a video of it, and then watch them where their ankles, hip, and knee joint centers are relative to one another before they land, and then the max collapse during landing. If they get collapse in the range of, say, if you look at the distance between your knees on that video, and their collapse is 30% plus of that total distance, they maybe have increased risk. And then the other great thing about that is you can use that longitudinally over time as you train them to show evidence of correction of those deficits.
Yeah, that's excellent advice. Kate, have you found that, have you used a test similar to that, or any other tests in assessing knee control within your athletes that you've worked with?
Yeah, we have, and I think in terms of it comes down to time and resourcing. And so certainly my biggest advice when the AFLW came in was, the physios had, very minimal time, 5 hours a week with, a list of 40 plus, was really just to look at their risk profile. So we know that, past history is a flag, certainly under the age of 20. So they would be the ones that I would recommend if you're time poor, is to look at history and to actually then look at those specific deficits, because we all know they may have been returned to play from an ACL, but they may still have residual deficits if the testing criteria mightn't be, based on evidence-based, and may have been based on surgical time or less experienced practitioner time returning them to play. So looking at, things like quad deficit, not everyone's going to have access to something like an isokinetic dynamometer, but those sorts of things, handheld dynamometry around sort of hip strength if you don't have access to some great equipment like a force frame. Some simple testing, like a one-legged rise test, has been shown out of the La Trobe group to sort of expose some hip deficiencies. So there are some basic tools that you can do if you don't have, access to be able to profile the 40 players in your squad, using some iPhone measurements. And I think it's fair to say in some sports that they're all high risk. So certainly adolescent females that are playing Australian rules football are all high risk. That are playing footballers in soccer, largely, they're all high risk. Some will have more identifiable sort of risk factors, but it's really just trying to kind of make sure that we're getting across the board, because unfortunately if you say 5 out of 10 are at risk and you identify them, and player 6 to 10 goes on and does their ACL, that's really tricky in actually in the elite world and in club land. So Kate might have something to add to that.
Oh, no, I think you've hit the nail on the head, and I think that's probably one of the biggest problems we have currently in the female athlete space is they're under-resourced. And so making sure you apply, I guess, injury prevention programs such as like FIFA 11 across the squad, and making sure you apply it like a vaccine. So it'd be wonderful to be able to really pick them out and spend a lot of time, but the reality is, and I'm sure for a lot of people listening, the reality is they think, all right, I've got 6 hours a week with this squad, or I've got 8 hours a week. And I think if that's the case, exactly what Kate said, pick out the ones that you know from the history, but then putting in place any of the proven injury prevention strategies across your whole squad, and really educating not just the players, but the coaches and everyone around, and trying to get the low-hanging fruit to get on board quickly. Because if you can get some of the key members of your squad doing, for example, a really good neuromuscular warm-up with a multi-component program to it, it might save not the ones you predicted or that you thought had increased risk, but someone else who had kind of flown under the radar.
And when we talk about these, I guess, injury mitigation strategies from a global perspective, from Kate and Kate's, your experience with working with teams who are possibly under-resourced and have lack of time, where is the best place to try and fit that within the program? Are you trying to do it multiple times a week where you're training the same capacity multiple times a week, or are you putting it in one block and trying to make it as high quality as possible? And if you get other components in your gym, great. Is that the kind of level that we're at the moment?
Yeah, I think it's certainly evolved. Like, I started with the Australian women's football team in 2007, and we had very little resources, and really, I was new into that space too. So, that it took a while for us to integrate it. Initially, it was, that the players didn't really have access to, strength and conditioning coaches, to gym facilities. So it was about trying to get it in where we could, and largely that's where the warm-up was effective. And then taking some of those principles, and like what, Tim said in terms of the actual mechanics of how they jump and land, and using some of those tools, particularly around sort of knee valgus, to be consistent across the cueing from to warm up to, jumping and landing, and then transitioning into more of the gym space when that became available. So it was about sort of grabbing opportunity when you can. That's certainly changed quite a bit, and in cricket, and I certainly know in football now, there's much more of an emphasis on the strength and conditioning component, as well as just their craft on the field. So it's then working within your team to make sure that that you're encouraging those strategies. And the interesting thing going into something like cricket is people say, oh, you're not going to see anyone with an ACL. Out of our 17 players in the national team, we have 2 with a past history of ACL, which didn't come about from cricket, but came about during their adolescence playing other sports. And that will then have an effect on them in terms of what we program for them now, because, you know, they've previously had an ACL reconstruction or an ACL injury, which means we have to try and mitigate against those risk factors for a long time. So even though you might think you know your sport and think, okay, well, that injury doesn't happen in my sport, it's really important to kind of understand what their past looks like and what their training sort of history is around that particular rehab. Because often, as I said before, they may have had that injury when they haven't been in a system, and they might have been in a regional centre here in Australia, or they might have been somewhere where it was just, yeah, okay, 6 months down the track, you're good to go, kind of thing.
You bring a great point there in regards to, and you spoke about before, the deficits that can continue post athletes returning to sport. Bourne, I know that you've done some work on assessing athletes pre and post injury. From the female athlete perspective, an ACL seems to be obviously one of the more common topics. What are you finding that the common deficits are, and how can we better address these as part of an effective rehab plan?
Yeah, it's probably the $1 million question, and Tyler can probably speak to this in a little more detail, because he's collected a hell of a lot of this data in recent time. We conducted and published a study last year where we looked at just the knee flexor strength and between leg asymmetries in a reasonably large cohort of professional AFLW players. And when we looked at the players who had a history of ACL reconstruction, but had completed successful rehab and returned to their pre-injury levels of training and competition, they were still significantly weaker in that surgically reconstructed limb. So they were between 30 and 40% down on that leg. I think that's a significant concern because, well, we know that the hamstrings are the primary form of muscular support for the ACL. And this evidence, I guess, supports other literature out there to show that that some of these deficits seem to be reasonably persistent and don't necessarily recover with rehab. And these girls were between 1 and 10 years post ACL reconstruction at the time of testing. We've done some more recent work trying to understand I guess the mechanisms of those deficits, and Daniel Messer, one of our master's students, recently published a paper where we used functional MRI to map the spatial patterns of hamstring activity or metabolic activity during a fairly exhaustive session of Nordics. And we conducted that in a group of athletes, both men and women, who had returned to sport from ACL reconstruction using a semitendinosus graft. And what was interesting to come from that study is that the previously reconstructed limb had about a semitendinosus, which was about 45% smaller than the uninjured contralateral limb in terms of volume, and similar magnitude deficits in terms of anatomical cross-sectional area. But they also had significant deficits in their ability to activate that muscle well. So they couldn't activate it. It was also smaller, and as a consequence, the torque generating capacity of certainly the semitendinosus, but probably the hamstrings as a group, was significantly reduced. In terms of how to improve that, I don't know, I guess, is the short answer. perhaps prioritizing knee flexor strength and using exercises that seem to preferentially target the semitendinosus, or perhaps its agonist, like semimembranosus, could be valuable. But there's certainly a lot more work to do in that space. Tim might be able to comment on some of his observations.
My comment is, don't take the hamstrings. That's the way you save them.
That was actually going to be my next question. Is it a larger case of, and not that we can ever tell a surgeon what to do, but actually educating athletes or teams on possibly there are better graft sites for the female athlete for success of surgery and or possibly mitigating injury risk? Do you think that's a component of education that's required, Tim, or is that too complex and too controversial?
No, I think it makes complete sense. And I think you have to follow the science and you have to follow the biology. So we know that there's multiple randomized controlled trials that show, as Maddie was pointing out, that the hamstrings are much weaker, and they're much weaker basically forever. So it kind of makes sense. You pull out the tendons of the hamstring. What you get in response to that is you don't get the same tendons back there. You get scar tissue. And of course, it doesn't have the same recruitment pattern or sliding mechanism as the native hamstring did. So what you have is these long-term, if not forever, hamstring strength deficits, and that's, as Matt pointed out, that's your primary ACL agonist muscle. And you also have more stretch out, and hamstrings grafts stretch out significantly more in women than they do, and though they stretch out across the board more, they stretch out even more in women than they do in men over time. So it's a looser graft in the end. But then you're also taking an athlete, very many of these athletes post this growth spurt, what they do is they rely, they're quadriceps dominant athletes, to stiffen that knee joint. So they're underutilizers of the hamstrings. Not only that, when they do utilize the hamstrings, females tend to overuse lateral hamstrings, which closes down lateral joint, which takes the knee into that inward position. So they underuse the medial hamstrings, and then what they're underutilizing, what they have strength deficits in, what they under recruit, and what stretches out more, you're taking from them. And from that perspective, from all those perspectives, plus the healing time biology, if you look at hamstrings, they take significantly longer to religamentize and recover that sort of ligamentous property than the other grafts do. So the problem is, for cosmesis reasons and other reasons, I can tell you, we worked with the surgeons here, the surgeons right across the river from me, and that work with the Cincinnati Bengals. They would only, the gold standard in the National Football League is everyone got a bone, tendon, bone autograft. Whereas the same surgeons who do bone, tendon, bone autografts, because they say that's the only thing I'm going to put in this high-level athletes, they would preferentially put hamstrings in female athletes who actually need those hamstrings even more. So, I know whatever graft you currently use and the current choices, you're kind of robbing Peter to pay Paul. But in this situation, you're robbing Paula and you're putting her at a great deficit, where with a graft that she's all in a neuromotor control area that is crucial to her.
Yeah, 100%. Couldn't agree more. Kate, have you had athletes that you have had this circumstance happen to, and then tried to find a surgeon that maybe used a different graft site than hamstring? And then the twofold question, if you have had those athletes with hamstring grafts, how have you gone about trying to decrease the asymmetry findings that Matt and Tim have spoken about?
I've done a lot of work with ACL rehab, and during my time at the Matildas, I also have worked at a sports clinic, largely with a ACL rehab base and working with surgeons. In Australia, the primary graft that is used is a hamstring. We currently don't have an ACL registry, which the Orthopaedic Association have been trying to get up for a long time, and I would certainly really have been a strong advocate for that, because we need to be able to see and track some of these and see who goes on to fail and who then, in terms of, and the grafters are part of that. So in my time during football, all players that had an ACL in that time had a hamstring graft, and most of them, we have 2 re-rupture, did really well, and it's about identifying some of those targets. We were lucky during my time at football to collaborate with Dave Opar and a group at Australian Catholic University in Melbourne in regards to tracking some of these and getting them into a biomech lab. And we certainly had some of the cohort that had previous, it was a small cohort of sort of 16, but had an ACL reconstruction using a hamstring. Some were able to get their hamstring strength back up, and particularly their medial hamstring back up when we were looking at their sort of Nordics and their sort of profiles. So it's doable, but you do have to really specifically target it, and it doesn't come without, problems, but it is achievable. And I think, like anything, the surgeon and the quality of the surgery is really important. So, we trusted a particular surgeon and have been able to use him. Now, that's a very biased sort of study and cohort, but it's doable. But I don't disagree with Tim in that it's something that you're always kind of constantly thinking about is should we be pushing them towards a patella tendon graft? Obviously, quads graft becoming a little bit more popular as well, but there's certainly a trade-off.
Yeah, so when Kate, go ahead, but when Kate alluded to the registry data, the registry data across the world is clear. Hamstrings fail more. They fail more across the board, and it's a significant difference. The question is whether it's clinically significant, and that has to be determined. Go ahead, Kate. Sorry.
No, I was just going to add from and Kate Beerworth, correct me if I'm wrong here, but from a clinical perspective, I feel like at the elite level, often we can access those biomech labs, and so we can get those deficits across the line and really work hard on educating the athletes, spend the time making sure before they go back they're ready for performance and they're not just kind of return to everyday life. Obviously, they need to get to a higher level, but I feel like there's sometimes that group of athletes that fall through the cracks. They're not quite elite level, they're pre-elite. They probably will come into our squads or the higher level squads at some stage, and they're the ones that I think are really tricky because you get them much later post-graft, and they're really hard to get up to speed and get their strength levels up and correct the asymmetries. And they often perceive they don't have a problem because they're currently not suffering. They don't. They're back to sport. They think they're doing quite well, but when you test them, you realise you've kind of got a greater injury risk for them, or you're a bit worried about them. Yeah,
I couldn't agree more. And I think not everyone's got access to, equipment and may not have access to, equipment that is going to sort of highlight deficits. I think the really exciting sort of space in terms of ACL stuff is looking at the asymmetries in landing, which you can't see to the naked eye, which something like a force plate is really useful in. But it doesn't mean you have to necessarily have one of those in your clinic or have an isokinetic dynamometer in your clinic, but having contacts in a network where you might be able to get them tested and really encourage your patients or your athletes that an investment for some testing, and it might be once or twice during the rehab, is a really worthwhile investment. Otherwise, you're just sending someone back blind, and they may have really obvious deficits, particularly around the hamstring. And if you can show someone there's a deficit, then that's it's a really useful tool at getting buy-in from the athlete that, hang on a minute, this is what your unoperated leg looks like. This is your hamstring testing results on your operated leg. This is your hip testing results on your operated leg. And whilst we know limb symmetry index has some problems, it's a really, pictures make the story go a lot greater. So if you can then highlight to the athlete that they've got some areas they need to work on, then that's where the testing stuff is hugely valuable.
Yeah.
Definitely. And we're seeing more sports medicine clinics or exercise physiology clinics having access to this sort of equipment. So once again, like you mentioned, Kate, if you are able to extend a hand within your networks or understand what environments possibly have some of this equipment, you may be able to have some data longitudinally across a 9 to 12 month rehab process and try and target certain components within that. We had a question regarding decision making around a graft choice and whether or not the sport that the athlete participates in possibly has a bigger indication on what sort of graft they should have. For example, a sprinter, definitely we don't want to take the hamstring, so would patella grafts be better options versus using a hamstring graft for jumping athletes where patella tendinopathy is possibly a high risk. So using the patella tendon as a graft site may actually predispose them to subsequent injury. Tim, did you have anything to add to that?
There are many surgeons that I know, particularly in Europe, who will say you don't use a hamstring graft at all in a female football/soccer player, just because they need that, the way they use their foot, the way they flex their knee and hip, that they don't ever sacrifice hamstring graft in a female football/soccer player, for example. But each athlete is an individual. It depends obviously on their history, and I understand these surgical decisions are really complex. There's a lot that plays in there. Again, somebody has a history of anterior knee pain, you're going to shy away from a bone tendon bone graft. I think the quads graft has a lot of potential. I've seen a fair number of those done. Last year I was in Julian Feller's operating room with Kate Webster, observing how he's doing his cohort, and they've got some comparative cohort studies that are coming out soon that I think are promising. But and then Martha Murray's idea of actually using a blood and a scaffold to try to repair the ACL and not have to take tissue from somewhere else to rob Peter to pay Paul. So I do think the athlete's sport is one consideration, an important consideration for grafts. Yes.
I can speak to the quads tendon graft. I've worked with 2 athletes from Julian Feller, and they have gone phenomenally well and restore range of motion quickly, minimal muscle bulk loss, and minimal, ongoing effects from those grafts as well. So definitely the quads tendon graft is an exciting, strategy that's starting to be used more in Australia. It's just how you continue to see the education of other surgeons to use that technique. As Kate alluded to, hamstrings still are the gold standard or the kind of the go-to for a lot of these surgeons. But hopefully
and I still should say, going back in the National Football League here in the US, you won't see a hamstring graft. It just doesn't happen. They do bone tendon, bone only. That is, at least in the US for the NFL, that is the only and the gold standard. But there might be a movement toward quads in some players in the near future.
Yeah, I think the key sometimes, is, we could probably, discuss graft choice all day, but
Sure.
in regards to, whatever graft they've had, it's just making sure that you identify the deficits, and you need some objective testing to do that. You need periodical objective testing throughout their rehab. And as Kate said, the earlier the better. It's really hard to start addressing those if you get that athlete 2 years down the track. So, you know, it's being able to assess them through the journey, and also highlight, okay, well, this is what we're working towards. We want to try and have some parity in terms of your limb symmetry, you know, early on, so then you can start working on the actual athletic, you know, components and the skill components. You want to try and decrease those deficits as soon as you can, regardless of the graft choice. And ideally, if you can, you know, try and get most of your athletes doing a intervention program or a neuromuscular training program, then that is actually then going to sort of, you know, potentially reduce the numbers of, you know, by half. So they're the sort of bigger picture strategies, I guess.
Yeah, absolutely agree.
We have one more question, just probably more so around the rate of failure. So Tim, you alluded to rate of failure of the hamstrings. What is the difference between female athletes when compared to male athletes with failure rate in our hamstring grafts?
So when you look at overall graphs is where most of the data comes from. What we see is, and this data is still controversial. So back in 2010, we published numbers. So this was my PhD student, Mark Paterno's work. Basically, we showed that the risk in 1 year, so our cohort, unlike many cohorts, most of the cohorts you see in Australia, because our cohort is based out of Cincinnati Children's Hospital, so it's a young cohort. So women and girls on average tear their ACLs earlier. They peak at age 16, where males are closer to age 20. So in this cohort that I'm talking about, it was about 60 to 65% girls, women in that cohort. And basically what we showed was at 1 year, a risk of tearing one or the other limb of about 25%. And then at 2 years, 29%. And over time, if you follow them out for 5 years, the risk is about a third. So at Mayo Clinic, we looked at a cohort of female football/soccer players, and we showed over a span of time, if that athlete returned back to if that young female athlete returned back to the sport of soccer/football, her risk of a second tear was 34%. Now, over time, when we first published that data, it was relatively early, and it was small cohorts because these were prospective cohort studies and we had biomechanical data on them. So that was in the range of 100 athletes to 150 athletes. So then the group in Melbourne, Kate, Julian, that whole group did a study, and they reported the exact same number, 29% risk of a second ACL tear. And then Leo Pincheski in Sydney, huge volume of ACLs, reported the exact same number again. So we knew that's valid with the consilience of all this data. So the risk across the board, if you're young, active, and you're going back to the same level of sport, your risk is somewhere between a quarter and a third of having a second ACL tear. Now the Aussie data is the data that Kate Webster and Julian Feller have is different than ours. They actually show in their cohorts that males actually are at somewhat greater risk, whereas our data clearly showed that females were significantly at a greater risk than males, but also the numbers are different. We had a majority of female athletes and they had a majority of male athletes, many, many more than female athletes, primarily due to AFL. So there's a difference, but it goes in different directions depending on which side of the world you're running and cutting and landing on. But in our part of the world, females are at a significantly greater risk, and they're at a significantly greater risk of tearing their contralateral ACL. And this is a series of studies we've done that we've seen it again and again and again, where what happens is, and Kate alluded to this earlier, is when you look at this stiffening strategy, for example, we did a series of studies where we looked at athletes longitudinally over time, and we would take them out to 2 years and 5 years. And Matt alluded to this earlier too. What you see is high force on the operated side, but significantly higher force on landing, even greater stiffening strategy on the uninvolved side, which again puts that side at even greater risk. So I would say, depending on what sport, what country you're in, there is differences between females and males. In our hands and our data, females are at greater risk, and females are at significantly greater risk of a contralateral injury because they demonstrate that stiffening strategy, and stiffening is even greater on the unoperated side.
That's fantastic insight and overview. Did you have anything to add to that, Kate?
No, I think, even though we're focusing on sort of the ACL athletes, similar profile for anterior knee pain as well, which is what we see a lot of in female athletes that are, not only field-based but everywhere. So, I think the common take-homes is get their hips strong, don't forget their rotators, and get their hamstrings, and particularly medial hamstrings, going, because, we've all seen that, typically quad dominant adolescent, athlete present in the clinic or in our teams. So
absolutely agree. And you have to keep that idea once they have that window of adolescence, once they hit their growth spurt, up until when they peak. So this is average age 11 to average age 16. These young adolescent females are at significantly high risk. And Kate's exactly right. Target the hip, target core, target neuromotor control of the trunk, the hip, where the symptom and where the load is and where the failure is at the knee, where the controllers are, is more proximal. So hip and core are absolutely crucial, but the distal controller, the foot, is crucial too. Rolling the foot, absorbing force there, and having alignment where it doesn't allow the ground reaction force to go lateral to the knee joint and collapse it inward is crucial.
Yeah, and I think, as Kate and I were saying before, in sport, certainly here in Australia, if there's a pot of money, female pathway is the last group to actually be resourced. So it'll, historically it's been, male, elite, female elite, male pathway, and then female pathway kind of is whatever's left. And generally, it's under-resourced and, with really new practitioners in that space. So they have, and they often have lots of athletes. So it's really hard to kind of support them. So, when you have a voice in sport like Kate has and I do, it's really about advocating to try and, the adolescent group, particularly in females, is the actual area where we need most support, because they are largely, very vulnerable.
Definitely. Tyler and Matt, you have obviously assessed a lot of athlete cohorts with some of the research you've done recently. If you were to identify some of the key assessments to try and identify some of these asymmetries we've spoken about, and or identify risk factors, what would be your suggestions as your go-tos for assessment for people out there that maybe don't have access to technology or could possibly use some form of field-based test or device?
Yeah, I think that's a tricky one, because a lot of these asymmetries we're talking about are invisible to the naked eye, really. You sort of do need something like a force platform to really get insight into some of the small differences that you do see in asymmetry because of prior injury. So, I mean, this question has popped up on screen about, the amount of error that there is, and even in lab-based measurements, but as well as field-based testing. I think I don't know if there really is tests available to be detecting these small differences. What do you think on that, Matt?
Yeah, look, I agree. I think measurement error is of our test is something that we very often don't consider. Component when interpreting those measures and assessing them time. I guess from my limited experience in working with athletes and elite athletes here in Australia, time sourcing is always a significant issue, and it would be great to be able to bring every single athlete into the lab and do really robust assessments on them, but it just isn't possible or practical. We have to rely on, on field-based. We have to take the lab to the field. I mean, that's really the only way we're going to move forward. But I think an important component of that is assessing the efficacy of those tests and, their reliability, their validity and things like that. I guess in terms of the data that you collected, perhaps you could speak. Tyler's just in the midst of sort of a retrospective comparison of about 400 elite soccer and football players here in Australia, where we did conduct a lot of this field testing. So as he alluded to, we had motor-centric knee flexor strength, AD and AB strength on Google platforms, and also a hopping mask in front of a camera. So perhaps you wanted to touch on really briefly, Tyler, just some of the deficits that you saw between previously injured and uninjured.
Yeah, so I mean the biggest one we've already discussed in length, so is the hamstrings and the asymmetry you see there. But I think if I was to choose the most valuable test out of everything that we looked at, I think the force platforms were definitely the next probably most valuable test, and that is being able to look at those asymmetries between legs and the injured limbs, and then once again we've already sort of touched on this as well, but yeah, you do see those higher forces on the contralateral limb. So yeah, to answer your original question, Selwyn, I think force platforms can be quite valuable, and I mean there's a lot with these portable force platforms that are becoming available, and there's a lot more research sort of coming out that sort of supports those notions of asymmetry. So yeah, if you get access to those in your injury screening protocols and return to play, I think it's got a lot of value. Otherwise, we didn't see a lot of differences in sort of hip strength between players with prior injury, and Nordboard scores weren't really different than those with prior hamstring injury either. And so we'll be doing prospective analysis on our data shortly, and hopefully trying to basically validate these field-based testing to see if they do have an association with future injury, which is obviously the more interesting results. And so we'll hopefully have those published over the next year or so.
Right. And with the testing that you were doing on the force plates, Tyler, are you just looking at bilateral counter movement jump and unilateral counter movement jump, or both, or just one?
Yeah, we had a bilateral counter movement jump. And obviously I think that's the sort of best way to go about getting that insight into symmetry and whether there is favouring towards one limb or the other.
Yeah, and then Tim obviously touched on the single leg jump and landing test as well. Tim, did you have anything to add in regards to possibly field-based testing to profile injury risk? And for people who don't have access, you spoke about the use of an iPhone. Any other tests that you think important?
I think if you're going to do a counter movement jump, or even just a single leg drop type measurement, even if all you have is a digital bathroom scale, it can be useful to look at differences in weighting one side versus the other, because many of these asymmetries we see are huge. So even though something like doing a counter movement jump off 2 bathroom scales would be full of error, if you have a scale that'll hold its max, hold its peak, you can observe the great differences in asymmetry you see one side versus the other. And asymmetries always work into our predictive algorithms. So getting that symmetry down, whatever parameter that, whether it's just direct Z vertical force on 2 force platforms or bathroom scales, that's crucial to seeing. And then once you have that, no matter what the errors in it, over time with your training, monitor that and see whether you can equal out side to side. And that's whatever tool, no matter how crude, I think is worthwhile to be able to monitor that, and especially monitor improvement towards symmetry.
Yeah, great advice. Kate, with some of the field-based tests, are you guys using anything like single leg hops for distance, or commonly we've seen in previous ACL return to plays the use of crossover hops and triple hops for distance? Are you using any of them as profiling or risk profiling tools at all?
As a part of a battery, sure. And I think it's helpful to sort of see that they've ticked that box. But the hopping, the crossover, the hop for distance, people find a strategy to do it and can kind of cheat in there. So I think rather than solely relying on that test, using those tests, which are quick and simple, but then being able to kind of know that there are other more perhaps sophisticated tests which are telling us a bit more as well. So I wouldn't use them routinely as a screening tool. If they've had a past history of a significant knee injury or an ankle injury, then I would use it as a part of a battery, but certainly with some other tests as well.
Yeah, I agree with that. I think it's there's definitely better things to use. But if you don't have access, then it's a good place to start, but you're going to have to look at a number of tests and not just one of those to give you your answers.
And for you, Kate, is there I guess bang for buck tests that you feel in your environment are really important for the success of your athletes at the moment?
Me, Kate?
Either or.
50% chance there. No, I don't think there's any one test for anything, and that's the challenge for all of us. But I think certainly if you're getting a new player into your squad, or it's really understanding their history, and I would be particularly wary of significant history that's happened during their adolescence, where they have you could generally assume that they haven't completed what we would consider sort of appropriate rehab, because the pain goes away and through no fault of the athlete or their parent or whatever, they just think they're fixed and they're fine. So I think delving into that is really crucial. It doesn't cost anything. It's just asking those questions. That's where I would that would start, and then depending on their profile, you might need to dig a little bit deeper.
And I think that's also where it's really important to, because often those athletes come in and they're technically not injured. So they don't see themselves as being injured, and they're perhaps, 2 years post ACLR, and perhaps have come into the squad and they're performing. And it's really important to educate the coach and the athlete that they're probably not at their performance. Even though they think they've been selected and they don't consider themselves injured, you've got to change the conversation a bit to not be about, not many athletes, and they don't think they're injured, want to know about injury risk reduction, particularly if they're young and they're coming in at 17, 18. But what they do want to hear about is how can I perform better and how can I kind of cement my place in the squad. So if you can sell it like that, we can make you better because we can see a deficit. So let's really work on that and translate that to performance. You'll get a lot more buy-in.
That's an important point from Kate. Absolutely. For whether it's primary prevention or secondary prevention, sell it as performance, because they don't really buy into the prevention as important as we all know that is. That's not what they're after. They're trying to perform at a higher level.
couldn't agree more. Kate Beerworth highlighted that really well in her presentation, and I think in all sports, if you can bring it back to how they can be more successful at their sport, whether that's by improving training availability and or getting them greater exposure to skill training, then they're going to be a better athlete, which will hopefully then improve their performance and decrease their risk of injury. Kate Beerworth, did you have anything to add to that?
Yeah, totally. I think you have to highlight, you know, their weakness and their deficits, and really push that angle that, you know, it's as soon as you start talking about prevention is not sexy, and you know, you don't know what you're going to prevent and you don't know who. So you have to be really careful if you go down that angle saying we're going to introduce this great injury prevention program, and the next day or the next 6 months you have a spate of ACLs, which if you work in female sports, sometimes, you know, you can't prevent them all. So you do have to be really careful about your language, because it's one way to not come back if you spruik it too loudly. And I probably did that earlier on in my career a little bit too. So I think age has kind of wised me up a bit.
We actually have tried to remove that term prevention altogether. We refer to it as risk reduction, because prevention can get you into trouble. Kate Webster and I published a paper on a meta-analysis of all the meta-analyses done on relative injury prevention, and it's just overwhelming data. You can reduce all ACL injuries by 50%. You can reduce non-contact ACL injuries in females by 2/3. It's overwhelming evidence. But can you prevent a single occurrence in a single athlete? It's unknown. You'd have to be able to have a crystal ball to do that. So, and especially in a place like the United States, where we have more attorneys than we have coaches, there's questions on using the term prevention at all, because then you're kind of making a promise that you're going to prevent something from happening. And to go backwards to that, in order to prevent something, you'd actually have to be able to predict that exact occurrence. So it's difficult, and we know we're never going to get rid of that term altogether, but just a bit of warning: risk reduction is a better, safer, less liable term to use than is prevention.
Very good advice, Tim. Definitely. The other component with, I guess, access, whether you're in a gym or a field-based, is there are iPhone apps like My Jump or My Sprint, and also the use of possibly linear transducers, which may be able to give you power measurements or velocity measurements, which you could then do limb to limb. It may not give you the asymmetry if you're doing a bilateral jump, but if you got athletes to do a single leg counter movement jump or single leg squat jump, you could get power and velocity measures from that. For some of the other people who are asking about possible field-based tests, if you don't have access to a force plate and or even the human track camera system that Matt and Tyler were talking about previously. In regards to other tests or other contributing factors to injury, Kate Beerworth and Kate Mahony, are you guys tracking wellness and or menstrual cycle as well in your cohorts to see if there's a factor contributing to injury risk or performance?
I'm happy to speak a bit about this. So I think a lot of the press, particularly in Australia, recently it's focused really around squads and clinicians tracking menstrual cycles and looking, or some big claims made, and this is blown up in the media a bit, I think, in terms of it gets exaggerated about like ligament laxity and what we know about who's more at risk at different times of their cycle and things. And the reality is we actually don't have the evidence at this stage. So in regards to whether a menstrual cycle should be tracked, I think if you're doing everything else and you've got the big rocks in place and you've got really good multi-component strength programs around and multi-component neuromuscular warm-ups and things around your athletes, and you're able to do all these other things correctly that we know have an effect in reducing risk, then I think yes, absolutely, then perhaps start looking at menstrual tracking, and you can maybe start collecting some data in that area. But really, we don't have the evidence that proves anything yet. So I'd say it should be a very small part of what you're doing in this space at the moment. And I'm really open to other panelists. Perhaps there's some opposing views here, but I think at the moment in female sport, that's kind of the stuff that gets picked up by the media, and it sounds really fancy and things, but really we don't have the evidence that to change anything based on where an athlete is in their menstrual cycle with regards to changing their training or whether they're at more risk one day to the next. And I also think it's a really important consideration that it's a dangerous path to go down to start talking about athletes that at certain times of their cycle they're at bigger risk. One, when we don't know it, but two, when match days can't be moved at the moment. And I think, and they will never be moved for everybody's different cycles. So I think it's also a really interesting area to get into. It's really complex. And at the moment, I would say the only thing that I really would track menstrual cycles in a player or in athletes for would be to pick up menstrual irregularities, which then need medical intervention. It wouldn't be for ACL risk prediction. And if you're going to do that, then you also need medical help in your program, because you'll need a doctor to be tracking that and following up appropriately. So you've also got to make sure you've got the resourcing to follow up. So Kate, I'd be interested in your thoughts, and anyone else on the panel who wants to comment on that.
Yeah, I totally agree. Like it is, and that's the unique challenges of working with female athletes is that hormonal component is certainly there, and it's underpinning, but we don't know what influence, exactly it has. I mean, there's been lots of studies, certainly in the ACL space, around hormonal influences, and we know that it's, the reason why females are more likely in some areas to go on and do an ACL is multifactorial. It's the anatomy is different, neuromuscular differences, but also the hormonal differences, but we don't exactly know. And so it's very hard to control that part of it when we don't have the data. So, and as Kate said, very hard to say, okay, I'm not going to play today, or I don't think you should play today because you're at this stage of your cycle. So it's an area where it's fantastic that we're starting to talk about it, and it's becoming the stigma of it in certainly elite sport is going, and the conversations are there. I know in certain sports in Australia, they've been tracking it for a little while. In cricket, where we will start tracking it for the 2020-2021 season, but largely, as Kate said, it's for the menstrual irregularities and just making sure that our medicos are across that. We're very fortunate at Cricket Australia to have a great injury surveillance system that's been up and running for a long time. So we may get some injury data down the track, but we're a long way off that point. So I think as Kate said, let's focus on our big rocks and do the basics well in terms of injury prevention, and then we'll see what certainly comes of that.
And I agree with everything both Kate said, that absolutely we need to go with what works. We know neuromotor training works, and that's what where we should be focused. The one thing I don't agree on is that we don't know what's going on. This is the one advantage of being the old guy here, because I had multiple grants on this in the mid-90s, and I've published over a dozen papers on this through the 2000s. So for example, we did one meta-analysis where we demonstrated that, yeah, there's an association. So what happens is when a female goes through her cycle and hits the peak of ovulatory phase, which is say day 12 to 16, say on average about day 14, the knee gets slightly looser. What it is it gets about 0.5 millimeter looser. So, it's almost immeasurable. That's probably not clinically significant, but the theory is because the knee gets looser, it's at greater risk. Well, we did another meta-analysis where we looked at when in the cycle women have a propensity to get injured. It's exactly the opposite side of the cycle. It's near day 0 at the start of men's. So then the knee is looser at day 14. Then the injury risk is greater at day 0. Now, some people will say, well, the reason it's in menses, there's insurance data that says women have car crashes more often around men. So it could be some neuromotor characteristic, not a passive laxity characteristic. But again, those differences are all small and relatively, you know, we don't know whether it's clinically significant. And there's also data, and we and others have published this data multiple times. It's also relatively apparent that those people on oral contraceptives those females on oral contraceptives have a lower risk of an ACL injury. So all those things are known. It's known that mid-cycle, the knee gets slightly looser by 0.5 millimeter. It's known that injuries clump around day 0, and it's known that oral contraceptives reduce the relative risk. But how you're going to use the data, how ethical that is to use the data, especially when you might get small differences, the interventions in those areas are going to be relatively small, where we know that neuromotor training can decrease the risk by 2/3. Why are you going to focus on a woman's cycle? In that sense, it's scary. And then, as both Kate's alluded to, the misuse of that information by a coach, an athlete, a parent, it's just too potentially great. So interesting. Again, this was really popular in the 90s and through the 2000s. 15, 20 years later, people are rediscovering these ideas, but the data is already out there. It's just been ignored because it's been around for 20 years.
Yeah, and I think it's probably been ignored because it is a minefield. Like it is really hard to kind of then go, you know, and to put it into context, and everyone wants to blame something for an injury. So, you know, like it's okay, well, let's blame the menstrual cycle. And I'm not saying that's not the case, but you know, it may be that they are incredibly weak, they're not conditioned, or, you know, let's be honest, it's bad luck. So
yeah, we got a large grant, a couple of large grants in the late 90s, 1998 through 1999, from the Orthopedic Research Foundation and from the National Football League, where we looked at all those issues within athletes, where we actually followed athletes through their cycle and then looked at strength parameters, neuromotor control. Out of all those studies we did, we only published one paper where we showed hip activation patterns were slightly different between cycles, but it couldn't be predicted. And I can tell you the error in these measurements and the variability from person to person to person, it's not very useful for predicting control, for predicting biomechanics, for predicting risk, any of those things. It's just not very useful. And that paper I referred to, we published in American Journal of Sports Medicine around 2011, the relative hip activation patterns across a woman's cycle. Again, we put a lot of years into that work and came out with very little useful information from it.
Definitely, yeah, a hot topic at the moment. And Claire Minahan from Griffith actually did a Q&A with us and with Matt Bourne that will be on the Vol Performance series, talking about this entire topic pretty much, and how it relates not only to performance but to injury. And she had some really interesting insights that you've all spoken about now. She also raised just some questions around its impact on strength, speed and endurance from a performance component as well, and how there's a real inconclusive data at the moment on some of those factors. So it's definitely an interesting discussion, and as you've all spoken about, the key is to actually use the research that we know has good validity around it, and that is neuromuscular control, strength training, and targeting what we know can have an impact on not only performance but possibly injury mitigation.
The key to that is there are some women who are really responders to their cycle that have a lot of variation and have a lot of deltas in performance and strength and biomechanical characteristics. There are others that have almost no variation to the cycle whatsoever. So you also keep, and the responders are probably in the minority. So for some women, it might be key. For others, it might have really no input hardly at all. And it's really difficult to tease out who would be whom in that scenario.
Fantastic insight today from all of you in regards to how we can be better preparing female athletes for success, but also better prepare them following injury, which is unfortunately common practice both in male and female sports. But as has been alluded to today, unfortunately, female athletes can be at a higher risk of some injuries, and the burden of that can be significant, both mental, physical, and financial. I'm going to apologise if we didn't get to a few questions from some people. I'm conscious of the time that we've had you all this morning and this afternoon from Tim. If anyone has any closing remarks or anything for the people listening, please jump right in. Otherwise, Tim, thanks for your time.
Thank you very much, Selwyn. Very much appreciated. Really enjoyed it.
And thank you, Kate and Tyler and Matt. Really appreciate your time. If people wanted to get in contact at all with some specific questions, is there, I guess we'll just go around the panel, if you have an email address you're willing to share, or if it's easier through social media. Tyler, if people want to get in contact regarding your research that's coming up.
Yeah, I think Twitter is quite a good place to get in contact and probably keep up to date with the research as it comes out. It will be posted up there. So my username's Tyler Collings 3. Follow me on Twitter if you want to keep up to date with that.
Thank you. Kate Beerworth, is there a way people could get in contact with you?
I'm not a prolific tweeter, but I am on there. So at Kate Beerworth is my my handle. So yeah, that's more than happy to hear from anyone that's got some questions. So thanks very much for facilitating today, Selwyn. It's exciting that we're putting it out there. And as I said, I think in my talk, it'd be nice to when we get the conversation that's not around female sports, just around sport, it'll be good. So we're getting there. Couldn't
agree more. Kate Mahony.
Yeah, I'm also on Twitter, although not on there a huge amount. Kate_Mahony_, or my N-Swiss email is just kate.mahony@nswiss.com.au. I'm happy for people to contact me. And thank you very much. I think these panels are really, really important, and I'm hoping the growth of female sport as we continue to grow, it also leads to lots of chances for practitioners to really have a career in this area, and that'll only help reduce injuries for our athletes, but also give people nice career paths in female sport. So yeah, thank you very much.
Couldn't agree more. Matty Bourne, your contact details, mate?
Yeah, mate. Twitter is probably the best, at mbourne5. Otherwise, email details on the Griffith website if anyone's interested. And just want to say thanks again for the invitation, Selwyn, and thanks to the other panel members. I certainly learned a lot today.
Thank you. Tim, I know you're a busy man, so don't feel like you need to share too many details, mate.
Twitter is definitely for me. I have 3 accounts just to keep myself busy. You can find me at Hewett1Tim, Timothy Hewett, or Tim Hewett 5. Just send me a tweet and I will respond within 3 minutes, guaranteed, night or day.
Perfect. I really appreciate everyone's time and reiterate Kate Beerworth's sentiments around continuing the conversation and better resourcing all practitioners working with female athletes, but just not with athletes as a whole. So thanks for your time again, guys. Really appreciate it. Enjoy the rest of your day.
Thanks a lot.
See ya. Bye.
Thank you. See ya.